Chairman. Uh, it's a very interesting topic, actually, talking about retinoscopy in today's world. When we were students, we used to have a retinoscope like this. And many of us seniors have done retinoscopy with this plane mirror and concave mirror. And later on, we switched over to streak. And then came the auto-ref. So what is the difference between retinoscopy? Since we have learned all these things in our last 30 years, we have done all these steps, we have gone through this. Today I have find that the postgraduates, they want an optometrist with them. When they go on to the practice, they say that this is not our job. Doing refraction is not our job. Optometrist will do. And many a time, when they go into practice, what they see is that he is the consultant and the optometrist is sitting with him. Optometrist has 25 patients. He makes glasses also, and he earns more than the consultant who is waiting for a cataract to come. So that sort of situation today is there. I find that those trained for retina, they don't know how to do a good refraction. So doing retinoscopy is very, very important. And I don't need to tell how to do the retinoscopy here. So this has been seen that when you have auto-ref versus retinoscopy scenario, in non-cycloplegic conditions, you will find that many a time it gives you more negative values. So it becomes difficult many a times to compare with retinoscopy, and there are several studies which tell that the retinoscopy is more accurate than the auto-refraction. So especially in non-cycloplegic refraction. There are other studies also which tell that the auto-ref gives you minus overcorrection. So many a time it gives you -5 and you have to give him glasses -3, and what the optometrist does is that he puts -5 lens and he gives the glasses because the patient can see with the -5 also with -3. So the subjective testing has not been done, and the auto-ref number that has been given is not right. So many a time we fail, and the surgeon is the culprit then, not the optometrist that you have. So the surgeon should know how to do a good retinoscopy, and also how to understand the auto-ref. In hypermetropia, on the other hand, it gives lesser value. So this should be understood, and especially in children. When you are doing in children, the accommodation plays a role, and when accommodation plays a role, then you have to do a good retinoscopy after dilation. And it has been found that after dilation, if you do auto-ref and retinoscopy, usually in adults, the difference is not there between the retinoscopy and auto-ref. But if you simply do in children, because the attention is required, they need some time to fix at the auto-ref, then you can get the refraction. So the refractive error is not proper, and many a time you fail in giving a proper glass. And many a time in the two eyes you do auto-ref, the readings would be different, whereas on retinoscopy you will find they are the same, so binocularity gets disturbed. So you must know retinoscopy, and then you can progress on to the auto-ref, which is a good screening device which can be used there. And in individual practice, one must learn to do retinoscope. So during residency, this is very, very important to learn retinoscopy, and then you can think of doing it on auto-ref. Thank you so much.
Thank you, sir. Retinoscopy